Simon and all of us actually, Louis. We're all going to talk to all of them about this. And actually, I thought this would be a rather good thing to do, is to actually bring it out into the open, because we have people who really do understand this in depth, and we're blessed with the folks we have. And of course, as a psychiatrist, I've seen many medics in my time. Indeed, I still do. And they always worry me, because it's not one single problem they have. It's quite a complex set of issues that they have. So on the back of Subodh Dave's recent historic achievement, which was to raise awareness of the wonderful work of Clare, Amandeep, and others at Doctors in Distress, we thought we'd put this together and bring you this right here. So my first task then, apart from introducing the task that is before us, which is to talk about medics and mental illness, is to talk about my dear friend, Clare Gerada, who's going to tell you a little bit more about the wonderful work that she and Amandeep and others are doing with Doctors in Distress. And Clare, as you will know, many of you, I've lost my script, Clare, so this is right straight from my heart and not from my brain. Clare is past president of RCGP. She's a current council member of BMA. She is a trustee and chair of Doctors in Distress. She's a medical director of Practitioner Healthcare Program, apart from being a really busy GP and all the other stuff that she does. I think the proudest thing for me was that she is a fellow, honorary fellow of the Royal College of Psychiatrists. But more than that, I think she's just a very, very dear friend. So Clare, if I can ask you to introduce the charity and the other stuff that you do.
Thanks, JS, and you are also a wonderful person. Somebody's already asked a question, why can't you all see each other? You actually can see us. We know who's on this call, but you can see us rather than we can see you. So let me just tell you, a few months ago, I had the honour of becoming the chair and I suppose the chief executive, heading up a charity that was set up by Amandeep, who I'm going to introduce in a second. And this charity, called Doctors in Distress, was actually established by Amandeep after the death of his brother through suicide. And its sole aim, is to reduce the rate of suicide, not just amongst doctors, but amongst all healthcare staff. We're going to try and do it through a number of ways. One is to lobby and to try and raise awareness, but also to try and create groups, supportive, reflective practice groups, where every single health professional who wants to or needs to can have access to a safe, reflective space where they can actually talk about the emotional impact of their work and actually get support from peers. And hopefully peers may well be able to identify that they might be struggling and might need to seek additional help. And having run a group for those that have been bereaved following the suicide or sudden accidental death of a health professional, I know only too well how the problem, especially amongst doctors, is hidden underground, because doctors do not like to access care. They do not feel that they're able to raise their hand up and to actually say they're in distress. So let me introduce Amandeep, who's just going to speak for a couple of minutes, because it was his idea to set up this charity, and he's now become a dear friend, supporting me, and I'm supporting him in this wonderful charity. So Amandeep.
Claire, thank you very much, and thanks to everyone for joining this webinar. So Claire pretty much sort of surmised, I guess, many of the reasons why I started up the charity Doctors in Distress. I'm not a medic, by the way. I don't have as many letters after my name as my fellow esteemed panel members. So I come at this, very much looking from the outside. But I lost my brother, Dr. Jagdeep Sidhu, who was a consultant cardiologist, in November 2018. And his case was very sort of typical of many cases of doctor suicide that I've since become very, very familiar with, in that he was a very, very hard worker and, really dedicated his life to the profession of which, I love and we all dearly love as well. But he probably went through quite a prolonged period of burnout, probably that started a couple of years before he passed away. And then that sort of gradually crept up on him and, as we all know, can probably identify with, just really consumed him. And it really got to a very, very critical point where he was signed off sick because he probably, and he never explained any of this in great detail, but he probably developed a very deep depression that came on quite suddenly because of his burnout. And 4 or 5 days later, after being signed off sick, he drove 90 miles from his house to Beachy Head Cliffs and very tragically ended his life. So I was really sort of inspired through a variety of emotions to raise awareness of not only my brother's case, but a lot of other cases of doctors' adverse mental health and ultimately with tragic outcomes. And the one sort of thing I would say at this juncture is I knew my brother very, very well. And he didn't have the vocabulary throughout his career to probably be able to express himself or reach out, for the help that he needed. But I know that in the way that he died and where he died, he wanted to make a very, very public statement. And through Doctors in Distress, I really want to make sure that message is carried forward. And I'm very grateful to, the likes of Clare and everyone else who's been involved, and particularly the back, sort of behind the scenes folk that volunteer so generously. So that's in no particular order: Anne, Mari, Roma, Bertie, Tia, Susanna. I wanted to give them a shout out to really thank them for helping me with what's my mission is going to be, to try and reduce doctor suicides, but really promote the value of doctors' positive mental health. So I'm looking forward to a great webinar, and thanks to everyone for joining, and I'll hand it back.
Thank you, Amandip. And before I hand back to JS, you have been an inspiration. I think you from someone who not actually heard about this issue till your brother killed himself, you've actually done a tremendous amount in setting up the charity and supporting me into taking it further. And we have put a QR code on the on this space, and you can see it. And if you use the QR code, you can go straight into our website, or if you go into the Doctors in Distress website, you can find out a lot more about what we're doing. But in particular, if you want to generously donate, please do. There are lots of questions coming up which we will take after the speakers have spoken, and we'll collate them and certainly bring them together. But let's first start listening to some of these the speakers tell us what they're going to tell us, and some of these answers may be answered. Some of these questions may be answered. So over to you, JS.
Thank you very much, Claire, and thank you, Amandip. And you are an inspiration to me too, because you are an awardee, which I'm going to talk about in a minute. So I wanted to talk about some of the work that Bapia have done too, because some of you will know that Imran Yusuf was a junior doctor. He was an immigrant from Pakistan. He came to this country. He passed his PLAB, and as soon as he passed his PLAB, this was 2006, I think, the poor man had difficulty getting a job. He got so stressed and depressed that unfortunately he took his life. And that embarked the Bapia's own quest for helping doctors in our own way. I wasn't the chair of Bapia then, but the team, including Ramesh Mehta and all the team, felt that this was really something we ought to do, not just to help them with education, training and other stuff, but also to, so in honor of Imran Yusuf, we set up the Imran Yusuf Award, which is awarded every year, or whichever year it is relevant, to doctors who've contributed particularly to doctors' mental health. So the last year's awardee was Amandeep Sidhu, and I'm so proud. He's such a worthy recipient. So now I think that without further ado, I think we should move on, because I want to be sure that we are interactive as well and taking as many questions as we can. And we have an amazingly impressive panel with Louis Appleby, Simon Wessely, Chaand Nagpaul, Ananta Dave, and Subodh Dave. So I'm going to start off with Subodh Dave first of all. So Subodh Dave is Professor of Mental Health at the University of Bolton. He's also a consultant psychiatrist and Deputy Director of Undergraduate Medical Education at Derbyshire Healthcare NHS Foundation Trust, and the Vice Chair of Bapia Institute of Health Research. He's a fabulous guy, because I don't know how he finds the time, but he's done scores and scores of marathons raising money for mental health, particularly mental health. And he's just done an epic ride, which in the climate that there was in Alaska, you probably chose the worst possible weeks, to be truthful, Subodh. First it was scorching heat, and then there was all sorts of wind and rain, but you went from Land's End right up to St. John of Groats to raise money for doctors in distress. and also raise awareness of suicide amongst doctors. So Subodh, I'm so pleased that you're here and you've survived this and you've delivered it in time. So tell us about your journey and as much as you can about this venture of yours.
Well, thank you all very much. I mean, I think it's really humbling to be here. I think hearing Amandeep's story. So I know I've just had so much of support from everyone, I think, on social media, my family, of course, and Amandeep, you rang up, and, you know, when people, it just meant a lot, because for me, it was a real challenge. I'm a runner, I'm not a cyclist, and to kind of cycle almost 100 miles a day was something that I knew was going to be hard, and actually was quite difficult, you know, with the saddle soreness and everything else. But I think what was always there at the back of my mind, I think it really came to the fore on the 5th day, I think it was, when we were, the weather really turned very, very harsh on the day we were riding in Manchester. JS, you were there, so you probably know how bad it was. And the morning we left, I couldn't have felt lower. You know, it was such a heart sink moment. And I think what really kept me going was the thought that how people have to undergo this. Sometimes people feel like this day in and day out. And I've seen this personally, and I'm sure all our attendees must have. I mean, we all have colleagues whom we've seen in that situation. I mean, I've unfortunately, and I'm sure I'm not the only one. I mean, not as close as your situation, Amandeep, where you lost a brother, but I've lost colleagues, you know, directly colleagues who I've worked with to suicide. I've lost medical students, you know, and I am in charge of training them, you know, and it's heartbreaking when you lose one of your students. But unfortunately, this is the reality. And I think what has struck me is how, you know, you'd have to wear a hard hat if you were going to work on a building site. But yet we send our doctors and nurses sometimes in situations where we know that they'll be exposed to a lot of stress, a lot of burnout, and in very vulnerable situations, and we don't really prepare them in any way. And I think that's something I really felt very keen to change. And when Anne and Claire spoke about doctors in distress, I mean, it was, you know, there was no question in my mind. I really wanted to do it for this particular charity because it's so dear to my heart. So that's how it came about, JS. You're mute, JS.
Yeah.
That would be the overriding message of the whole of COVID-19. You're mute.
You're mute, yes. Well, it's not often that I get muted, but Zoom has learned, I've learned to mute myself. Now, Subodh, so this was quite a stressful thing for you, I know that. And when you hit Cumbria, the stress became even worse, wasn't it? But we're so proud of you because you managed to achieve what you know, I've never known anybody to do this, certainly not a medic or a psychiatrist. Can you tell us a little bit more about, tell us about, in terms of mental health and healthcare practitioners, let's broaden it a bit. What are the issues? Why can't they access healthcare? Sometimes when I was medical director, people used to say to me, well, we need to prioritize healthcare professionals because they need to access services very quickly in order that they can get better, in order that they can treat patients. But then it makes us feel as if we're a bit elite, isn't it? I mean, how do you manage that kind of, you know, difficulty when it comes to access of care?
Well, it's difficult, isn't it? And I think this is the real challenge. And I think as a trainer for medical students, I started a program called Dr. 1 in 4, where we have doctors with lived experience of mental illness come and talk about their experience to medical students. And the reception it has had has been absolutely phenomenal. You know, I think we are used to getting very high ratings for some of the programs we run, but this was by far, you know, it exceeded anything that we've done. And we in fact even had, you know, interlopers from primary care and the acute world who decided to, because they heard about the program, they wanted to come and participate in our program. So I think it touches a chord because, you know, we are all medics in healthcare profession. We can be quite competitive. There is that sense of, you know, not wanting to appear weak. And I kind of related to that. You know, on the day, I think, you know, I still remember 3 hours leaving Manchester. It's raining 40, 50 miles per hour gusts. And and some of us still thinking that we must carry on, let's not give up now, So I think it's hard to draw that line. And I think certainly as a psychiatrist, I know that even being a psychiatrist, it's not easy to diagnose depression in somebody who's very close to you. It's not easy to spot substance misuse problems in somebody who's working next door to you. It's not easy to do that. And it's not easy to ask for help. So it's not easy to draw a distinction between when does, stress, burnout become mental illness. And I think that's something that we all struggle with. We don't know when to ask for help. And are we kind of making an excuse for ourselves? Am I having a duvet day? And there's a lot of talk around that, isn't it? So I feel that there's a lot of work that we can do. And that's what we've been trying to do, is to help people understand how to seek help, how to not feel guilty about seeking help, and how, just because you seek help doesn't mean that you're trying to have an easy way out or something like that. And I really feel that people, like Amandeep's story, and like, I guess, this is so common that I'm sure that no one is untouched by it. I think it's pretty much impossible, I think, to not have a colleague who's been through a fairly severe bout of depression. And I think it's also an awkwardness. And I think I had this, as a runner, and I have minor injuries every now and then. I think so. I was on crutches a few months ago, and so many people asked me, so what's happening? I walking through the corridors of the hospital, everybody was stopping me and asking me. In fact, 2 weeks before then, just, Prof. Bhomik had passed away. So I'd actually sent a note out, how close he was to me.
He was, yeah.
Note out saying I was quite upset. And only about 3 people kind of, approached me and said something to me. So I think we need to learn how to reach out, because I think we don't know how to do that. We've forgotten how to do that.
Indeed. Let's, thank you very much. And Amandeep, our heart goes out to you and your family on your loss. So I'm going to pass on to Claire to introduce the next speaker.
Thank you very much. I said I'm on mute. They're probably in the same place, aren't you, Subodh and Mantant? Are you in the same building? Because yeah. I have to confess, there are 2 husband and wife couples, and it's up to you, audience, to identify who's married to whom. But Ananta is a wonderful lady. Not only is she now the president of the British Indian Psychiatric Association, I think you're the first female to hold that position, but you also hold all sorts of, you're a consultant psychiatrist, a child psychiatrist, and you do an awful lot of good work. And I've looked up your Twitter handle, and it says that what you've put there is, where there is love, there is life. What a lovely, lovely statement to make. So over to you. You've done some work going off to Australia and looking at the Church's Fellowship, and there's a lot of questions. If I can just, I know you're going to talk for a few minutes, but people are asking in the chat box, why are doctors, why don't they approach for help? Why is it that we sit back and just suffer in silence, really? What have you learned from your studies, Ananta?
Thank you, Claire, and thank you for inviting me to be a part of this very important discussion. And it began on a very emotive note. Amandeep, listening to you, it just really struck me to the core. And, one of the reasons why I think this is so important to all of us is, I think, there, but for the grace of God go I. We could, any of us, be in that position where we feel helpless, hopeless, and we've been unwell. And I have been in that, I've been in a position of, say, great shame and embarrassment several years ago when I lost my mother, and I was subsumed by grief, which quickly morphed into depression, I think. And I didn't feel able to say it as it is or ask for help for what it was. So there was a lot of slinking about in secrecy while taking time off work and trying to then get back to work and pretend everything was okay. So although I did not get as unwell as some other people have, there's an understanding of what it might feel like. In my present role as medical director in the NHS, in Lincolnshire Partnership Foundation Trust, I also am acutely aware of the responsibility I have for the well-being of staff and making sure that we've got the right things in place for staff, all the medical colleagues as well as other members in the trust. What I'm going to share with you is a combination of my insights from the Churchill Fellowship. I actually was awarded a fellowship to go to the US, to the United States of America, to look at how they work towards suicide prevention in doctors over there, and to see what it is that we can bring back to the NHS. So it's a combination of my roles as a medical director, as a Churchill Fellow, as president of BIPA. So one of the first things I would like to say is that if we are to change this culture, we've got to begin very, very early on. And that is early, both in terms of the start of the medical career, that is in medical school, as well as very early on when people need help or become unwell or come under stress. And for us to be able to do that, we need to actively challenge the current culture, which is one of silence and secrecy and shame, because of some automatic assumptions being made that if you have mental illness, you cannot be a good doctor, you cannot develop in your career, you are weak, you've somehow not managed to overcome a problem, and that you are unlikely to be, trusted or, taken seriously by other people. So this kind of automatic assumption almost that we've made between being mentally ill and therefore not a good doctor is really needs to be turned round on its head. And from all the numerous doctors, colleagues, and friends whom I've met who've died tragically, who've taken their own lives, I know actually that once people are in a good place, once they're able to recover and are given the right help and listened to when their suffering is validated, they make excellent doctors. They actually develop unique strengths and insights and empathy, which is lacking. And we need a group of doctors from diverse backgrounds to make up our profession. So really that message needs to be instilled right from the beginning, from medical school. Because if you're waiting till they become qualified doctors, it's actually a bit late. We need to be able to challenge this right from the beginning. And also there needs to be continuity of pathways from medical school to training to hospitals. That's what I've observed in the US, that the same person had ownership of this and there was a continuous pathway. The second thing so I'm just being very brief about it. I'm happy to expand afterwards. The second thing I've seen is that if we want to challenge the culture and if we want to make people feel comfortable about coming ahead, working within organizations, senior leadership, I include myself in that, I'm a board member, we really have a big responsibility to make it a priority to keep talking about health, well-being, and mental well-being of our staff, and link it not only, for the sake of the doctor's own welfare, but link it to how it is important to have healthy staff to deliver good care. Role model behaviors as senior leaders about taking time off, about being able to talk about difficult things, about introducing the emotional aspects of ourselves into a conversation, and being able to live in the fullness of our identities, and enabling people to share stories sensitively. So people who've recovered have very powerful stories to tell and it resonates. But we need to be mindful of the impact on them, but support them to tell their stories. So create an organizational culture where this is seen as important. And it's not just about waiting for somebody to become ill. I think the things that put a person on the path to stress, burnout, illness, substance misuse are about everyday working life. How do we make it livable and doable? What about our regulatory practices, our protocols, disciplinaries? So it is a combination of things that we need to get right as an organization to change the culture. And it begins with somebody having accountability at a senior level for the well-being of staff, like a chief wellness officer, which I saw in the United States. The third thing I would say is about being a psychiatrist, the role of psychiatrists themselves. A lot of the stigma that doctors face when seeking help comes internally from within the profession. And when we are treating and providing care to people with mental illness, be they staff or patients, we advocate for them. We stand up for the stigma that they face. And we talk about hope, recovery, trust, and therapeutic relationship. And if we don't practice it ourselves, either when it comes to our own health or when we are caring for others or supporting others to access help, then we are not, being fully authentic as psychiatrists. And we also have a role to play in setting up services, working with other professionals, both non-medical and other specialties within medicine, to set up the services that are required to treat people and to provide care for doctors. So we as psychiatrists really need to be at the forefront of leading this change of challenging the stigma and providing help, and training the doctors of the future to actually provide care to other doctors, to make sure that there is capacity and resource within our profession to be part of that care system. So these are some of the things that I've learned, very briefly. And the last thing I would like to say is that within help seeking, within the medical profession, there are inequalities. We know that for some people, whether it is students, trainees, or SAS doctors, or females, or people from a Black, Asian, minority ethnic background, there might be, or even from an LGBT background, there might be people who find it more hard to seek help, who find their distress not validated, who don't feel that they're taken equally seriously. And it behoves us really, and COVID has taught us that, it behoves us to look at the inherent inequalities within our profession and see what it is we can do to address those when we are encouraging help seeking. Thank you.
And how amazing for you to say that, because again, mental illness, whilst it affects everyone, there are some people that it disproportionately affects, and the more isolated, those we found in my sick doctor service, that doctors from who are international medical graduates, locum doctors, and there tends to be an association between locum doctors and doctors from the BAME community. I mean, is that what you find as well, and what you feel as well?
Absolutely. And that is something I think, yes, sometimes it can feel to them that they are in no man's land, or there's no sense of belonging, or there's no network and connectedness. And we know how important a sense of connectedness and belonging is in order to recover. So we really need to be able to foster that becoming belonging, the best of ourselves and realizing our full potential. So really important to look at specific groups as well. Thank you.
Absolutely. And a sense of belonging, of course, is what the Roger Klein report found, was that doctors from overseas didn't feel they belong. Ananta, thank you so much. There's lots and lots of questions, and so we're going to pick up this when we have the debate. But I want to now move over to Lewis Appleby, and you've already heard a bit of an introduction from J.S. about Lewis. Well, Lewis is a very good friend of mine, and we go back many years. In fact, we go back to my first date with my husband, who was also one of the panelists. And many moons ago, Lewis was there at the start of our love affair. So I always, whenever I see Lewis, I think back to those days, now nearly 34 years ago. But Lewis, you have for many years been what must be called the suicide czar, which I'm not sure how that sits with you, but you've done some spectacular work, not only in doctors, but right across the board in trying to reduce the incidence of suicide across Great Britain, and in particular across England. But do you want to talk about some of the work you're doing, and particularly if you can pick up some of the themes about doctors, but don't worry if you don't know specifically about doctors, if you can just talk about the work you've been doing on suicide prevention.
Well, thank you very much, Claire, for that slightly unusual introduction. I wonder what possible images your introduction has conjured up about the role I played that night. So I'll come back to that at some later.
A matchmaking role, Lewis.
As people will know, it's World Suicide Prevention Day tomorrow. Become an annual, quite important event, and it's a time when those powerful personal stories come to the fore, as they have done already tonight. I want to say something about that, but I also want to mention some of the data. In the end, we have a responsibility to place the incredible, powerful personal narratives alongside what we know about the figures. For me, this is not a new issue. It goes back quite a number of years. It's actually 20 years ago, round about now, when there was the death of a young psychiatrist working in London. Claire, I think you had some knowledge of that case as well. As a young doctor called Dr. Emerson. And some of us around this call actually were involved in different ways. I had a connection with the inquiry into that death, and it had a very high profile and a very profound effect on a lot of people. So it's a young doctor who took her own life. She also killed her baby. And in the inquiry, one of the most important findings was the difficulty in receiving what you might regard as conventional care as a doctor. So in other words, the paradox was that even people in the profession, people who knew their way around the medical system, seemed to find it more difficult to get the care that they might need. And it occurs to me that 20 years on, we are still to some extent talking about that issue. despite the great work, Clare, that you've done through the Practitioners Health Programme, it is still an issue for many doctors, that uncertainty about where to look for care. For the doctor on the care side, if you see what I mean, how to provide care, how to do it in the right way for a colleague or somebody referred to you by a colleague. Those issues of shame and stigma, and also that abiding sense that somehow mental illness is weakness and will be perceived as weakness and will damage your career. That still runs very deep in doctors, even now. So what are the facts? Most people I meet believe that suicide rate in doctors is high. In fact, in this country, the suicide rate in doctors is not high. It is not high in doctors in England and Wales. And in fact, when you compare the suicide rate to doctors, to the general population, people of the same age and sex, what you find is that for male doctors, the rate of suicide is actually low. The rate for female doctors is pretty much the same as in the general population. So given what we've seen in over the years in what's been reported in the literature, something has changed. It looks as if there has been a fall in the rate of suicide in doctors in this country. I think there's also been a change in how it's measured, and that has had an effect. It's probably also true that there are differences from one country to another, and some of the reports come from the United States, where the situation probably is different. Some from Australia may also be different there. So there are international differences too. And the figures also reveal something quite important, which is not that the rates are high in either males or females, but there may be a male or female difference. So the risk might be greater, proportionally greater in women. And that's certainly something that's also true in other health professionals. The risk in female nurses, for example, is higher than the risk in the general population of females. So maybe something about the role of women in the health professions. Should the rate be even that high? You could argue that the main drivers of suicide rates in the population are poverty and lack of education. And those two things don't apply to doctors. So the fact that their rate is the same as the general population, maybe it should be much lower because the standard risk factors are not there for doctors. Their rate should be much lower. And it still amounts to something like 16 doctors a year who take their own lives in England and Wales. And 16 doctors a year is already far too many. It may not be the highest figure you'll hear in epidemiology, but it's too many. It is tragic when you think of why people come into the profession. People who want to help others, people with a strong sense of public responsibility and public duty. For it to end in that way is nothing short of tragic. When you think of people who are already in contact with the services that could probably help them, the fact that they don't benefit from that proximity is nothing short of tragic. Well, we know quite a lot about suicide in general. We certainly know that suicide is never or very rarely caused by one thing, and suicide prevention is very rarely one thing. So in the case of doctors, we're looking at a range of influences, a range of risks. Some are in the workplace, the stresses, the burnout that people have referred to already, the fear of falling below what are sometimes very high self-imposed standards. Doctors are very high achieving, high expecting individuals. Alcohol, access to potentially lethal drugs, problems at home. It is often a combination of work and home and personal problems that lead to tragedy. And then there's one other thing. About 5 years ago, I was asked by the General Medical Council to look into the risk of suicide in doctors who are undergoing investigation. I produced a report for them, and I think it's fair to the GMC to say that they have acted fairly extensively on what came out of to that work, the recommendations that came out of that work. One thing that was quickly apparent was how many doctors felt that the investigative system, the regulatory system that we work in, could be quite heartless. And so a lot of people contacted me, people who had been through a difficult time, obviously come out the other end and still were in the profession, but they felt that they had never really got over the experience of being investigated. And I think sometimes the wider world underestimates the profound effect on the medical profession of having something so personal as your practice, something that you identify with so strongly as the standard of your medical practice, having it challenged and criticized publicly. The effect of that is very damaging for some people. Doctors who go through investigation, they don't all become depressed, but many will still describe feeling trapped, feeling humiliated, feeling unjustly treated by an impersonal system. So when we think of what needs to be done to help doctors in the workplace, in their personal lives, we also need to think about the responsibility of the wider health system, employers, peers, managers, but the wider regulatory system. And society too. Society has a responsibility to ask itself how much blame it wants to attach to doctors when things go wrong, and has to ask itself what the effect will be on the morale and, in some cases, the survival of the profession. So yes, we should look after our mental health better. That's certainly true. We should be better able to get access to support when we need it. We should have proper induction when we start working for a new organization. We should have good working relations. And we should have facilities where we work that are respectful. I'm thinking particularly of young doctors, junior doctors on call. But in the end, we also need to ensure that a profession that is inevitably demanding doesn't also become destructive. And that is a public responsibility as well as a professional one.
Thank you so much, Lewis. And of course, what you're saying is right, doctors should have lower rates. If you look at the risk factors on the whole, we tend to be well paid. We tend to have quite a secure employment. We tend to have reasonably good social networks. So it is an issue. And if you think, what, 16 a year, that's just over, you know, 1 every 3 weeks. So thanks very much. And there'll be time to pick up questions because there's lots and lots of comments. Right, now over to Simon and his lovely pink headphones. And in fact, I'm going to hand over to JS, who will carry on chairing this session because I wasn't meant to introduce Simon. Sorry, Simon. JS, over to you.
This would have been your chance, Clare, to tell publicly, but anyway, you've lost that chance, and that chance falls to me. I know this is a serious subject, and what Louis said, I could have actually captured that and put it into a suicide prevention strategy, exactly as it comes from the Tsar of suicide prevention, and I think hopefully we're capturing this and we're going to do something with it. But it's my task, my wonderful task, to introduce Simon Wessely's headphones. Sorry, Simon Wessely, beg your pardon. So Professor Sir Simon Wessely is Professor of Psychological Medicine at King's College. He is Director of King's Center for Military Health Research and past President of the RC Psych. He was knighted in 2013, New Year's Honours for services to military healthcare and psychiatry. And he is, it's a great privilege for us all because he's the world's first Regius Professor in psychiatry, and I remember that lecture very well when you were invested as Regius, and what a wonderful lecture that was too, Simon. And Simon, of course, has done a huge amount of work, not just in military health, but altogether in health. And I want to welcome Simon and tell us more, please, Simon.
Oh, JS, you're so sweet. Thank you so much. I'm going to book you for all my introductions. Actually, Lewis was also present at another key point in our lives when we were all together in Galway in a restaurant above a pub, and we just had our young son, who was, I think, 6 or 8 weeks old. We weren't quite used to this, and we all left the pub together, leaving him under the table in the restaurant until halfway back to the hotel. Lewis said, "Aren't you missing something?" And I had to run back, and there he was under the table. So now it's called doing a Cameron, I think. So yeah, Lewis, you're always present at the high points of our lives. Look, I haven't got very much to say at all. I mean, I'm not a suicide expert at all, and certainly nothing remotely touching Lewis's expertise or wisdom that he always shows. He is truly remarkable, as are the others. I think the only thing I'll talk about a little bit is some of the work we've been doing recently, just to put it in the COVID context, because I don't know if JS, you've noticed, but there is this kind of pandemic going on around us at the moment, and which allegedly changes everything, but I'm not sure that's actually true, even in doctors' health or in any other area. What it's done is accentuated things that were largely there already. And if we look at the mental health of the whole workforce, because we're not just talking about doctors, of course, we're talking about the whole of the NHS workforce, the first thing to remember, just like the mental health of the public, is that before this pandemic started, things were not great. And there is a tendency that we all have to see, you know, everything went wrong in March, a bit like, you know, the summer before the First World War that everybody remembered was always bright sunlight full of crickets and croquet playing, when actually it wasn't. It had rained more than any summer had done in the last 20 years. And I think we're doing the same to see even the more immediate past as saying everything was fine then, and then COVID came along and wrecked it. That's not true. Mental health of the workforce in the NHS has never been great. It's never been a good example compared to some other organisations, and indeed compares unfavourably with the armed forces, which is what I've spent the last 20 years studying in many respects. One thing they do have in common, of course, is for the reasons that Lewis has said, actually overall suicide rates in the armed forces are lower than you would expect, partly because, of course, they have a job, they have cohesion, etc., and they're also very healthy. So some of the major risk factors are not there. But of course, it does also happen and is desperate and does, well, we think, Lewis is going to tell us because he's doing the study, but we think it does rise when you leave the armed forces and separate out from that organization. So what's COVID done? Well, the first thing is that there's absolutely no doubt at all that COVID has had a substantial effect on the mental health of the entire population. The easiest way of looking at it is this time last year, about 1 in 10 people were suffering from major depression. Now that figure is 1 in 5. So there's been a change, and there's been an even larger change in anxiety and fear. So the question is not, has the mental health of the NHS workforce got worse, but has it got worse than everybody else? And the evidence is a bit unequivocal, it's a bit unsure on that one. Some studies say yes, others, one of the ones we did, population studies this is, that include pre-COVID data, say no, it's gone up in proportion to the rest of the population. And what difference there are often explained by the makeup of the NHS workforce, which is not representative of the workforce and of the national workforce. And obviously, as you know more than anyone else here, that people from a BAME background are much more likely to be working in the NHS and more likely to be working in the more difficult jobs. And so that's also one other reason. So we're not sure about that, but what we are seeing is really worrying results from surveys of the level of distress. And we haven't got a very good survey yet, and we're doing a big one, NHS check, but even that is very struggling with response rates, and Manchester will be involved in this, but it's very difficult now, I think, because of a burnt out workforce maybe, or an over-surveyed or a fatigued workforce, to get good results, so good responses, so everything is a little unclear. But we are seeing certainly high rates of symptomatic distress. What we are doing is now going on to interview people to see, because I don't believe, I don't believe in a sense our own data that 75% of the workforce has PTSD. I think they have stress-related symptoms, but I don't think that's going to all be PTSD. And we will be interviewing people to see what the true levels are. But I think the trend of an upward trend across the population is also being reflected in the NHS. And we also think that, I think Clare will talk to this much more than me, is it isn't just, it's not concentrated where you might imagine in our, famous frontline workers, a military term actually, which I'm not sure is very helpful in a non-military context. And there's certainly many who report having had a stressful but actually challenging but actually rewarding experience. I think it's often people that you don't think about so much. And I don't think that it's all going to be related to, the kind of single trauma causing PTSD that is you often see in television series, but you see not quite as often in real life. It's going to be more complicated than that, and it's also, I think, getting worse now, possibly because actually going back, going back to some of the old ways are actually more worrying for many people than the new ways, and also the fact that some of the divisions that were always present, COVID has accentuated. And my last word is really on that. I don't think Lewis did touch on that much, but one of the things pandemics have done throughout history is invariably, without exception, they always increase inequalities. And there has not been an exception. And it's already clear that this pandemic is doing the same. It is increasing that. And inequality, like what's coming next to the economy, are two potent causes of serious mental illness and, sadly, suicide. And I'd love to end on an optimistic note, but I'm afraid I actually can't, because we haven't yet felt the beginning, really, of the economic dangers that are coming. And as Lewis, of course, and everybody here knows, the link between recession and suicide is, sadly, I mean, it's so proven that it's almost not worth researching. I mean, it is a given, a fact, and that is not a happy point to end, but it is where I will end.
Thank you very much, Simon. So I think that, well, it was a realistic note rather than a pessimistic note, isn't it? Because,
yeah.
Because, well, as we've seen in previous pandemics, the major pandemics, that there is always a downturn in the economy, and also that affects people's mental health. Can I ask you about this huge work you've done about moral injury? And I wonder whether that affects NHS staff much more than it might. I'm not saying other people are not caring, but by nature, you are of a caring nature, which is why you go to work, look after people. And is the extent of moral injury worse in NHS staff? And what do we do?
Okay, let me just introduce that for those who are not familiar. This is a term that actually, again, has come from the military. And it describes a situation, which is not a psychiatric disorder, I should say that, but what it is where you're put in impossible situations where you have to do things that you feel you shouldn't be doing, don't want to, can't do, etc. And it actually emerged out of peacekeeping duties in former Yugoslavia, where British and many other nations' soldiers were forced to watch atrocities being committed, which they couldn't stop because the rules of engagement did not permit them. Now, they knew they could have done that, but they were not allowed to. And that was almost where it came from, where, you know, normally they are people who like doing things and stopping things and actually, you know, stopping terrible things, but they couldn't. And the analogy, and we've seen it in other places as well, again in the military with direct relevance to the NHS, where also people are put in situations where they feel the equipment that they have is insufficient to do the job. And if they had the right equipment, then they wouldn't have seen their colleague injured or killed, or indeed, finally, where they feel that it was their mistake that caused someone to be killed who shouldn't have been. And the analogy with the NHS is obviously where people feel they've not had PPE, so they've been put in a position of exposure they didn't need to have done, and where, you know, this time last year, they would have been able to treat someone. This time next year, they would have been able to treat someone. But during the pandemic, there was a time when they weren't, because of overcrowding, lack of equipment, lack of space, etc., lack of experience, all of that. How large that, we don't think that was as large as we predicted, because, you know, as usual in Britain, just in time, we managed to expand and develop what we did. But there was a time when that was happening. I don't think it's going to be the scale that we thought it would happen. I think that things were better than that. But it's one of the things we will be looking at. It's something that you really have to talk to someone. It's, as I say, it's not a diagnosis, but it is a state of mind. And it's not necessarily the province just of psychiatry. It's also the province of padres, of chaplains, of religious people, of your friends, your colleagues. It needs to be seen in that way. And most of all, and this is the last point I'm going to make, it is very much an issue for whoever your superior is, be you in the military, in the NHS, whatever, and it's how they manage that and how they take the responsibility for that, how they can carry the guilt, how your line manager supports you is probably the most important determinant as to whether or not you get into this problematic situation. And actually, I think during the height of the pandemic, a lot of junior doctors tell me that they never had such good teaching. They never had such good leadership. They never had such good support. It's a bit of a slap in the face for all our generation, JS. That it took a pandemic for them to actually get real, really powerful support. And many of them that I've been talking to say, I've never had that, never felt so part of a team, never had such great supervision. And now they're not possibly slipping back. So that's what I'll say on that.
Thank you very much, Simon. And I've allowed you a bit more time because there was so much that you said. Absolutely. Not because you're Claire's husband, not your pink headphones neither. Now, Claire, you're going to do the sum up, so I'm going to do the next bit, which is to introduce. We just swap roles there, Claire, just to keep up to time. So our next guest is Chaand Nagpaul, who represents 150,000 plus doctors. No pressure there at all, Chaand. And of course, that is just a simple glass of water that you've just had. Chaand is the chair of BMA Council. He's past chair of GPC. He has a number of accolades to him. He's also a GP in a very busy London practice. He got a CBE in 2016 or 15, I think, for his services to medicine. And he's, above all, a hugely important man in terms of what we've done in the last few years in terms of, doctors' health and other stuff that the BMA does. So we're really privileged that, Chaand, you're here. So, and I think the BMA have done a lot of work on medical students and also junior doctors and senior doctors. So perhaps you might share that with us.
Thank you very much, JS. Hello, everyone. Can you first hear me? Yes? Well, I feel quite underqualified. I'm not an expert in mental health, but I will want to share with you the work that the BMA has been doing. And JS, we actually have more than 160,000 doctors now as members, and it's a very serious responsibility. We're called a trade union, and when you hear that, you hear about pay terms and conditions. And I want to be absolutely clear that part of terms and conditions is the conditions that allow for well-being, that allow for doctors to feel professionally valued, rewarded. So this is core to, from my own perspective, the role of a trade union. We're also a professional association, and we have, for those of you familiar with the BMA, a large part of the BMA's work is in the professional arena. We've done a lot of work on qualities and on NHS culture, and we've got many staff devoted to that cause. We're very committed to supporting doctors in distress, improving well-being. We run a free 24-hour counselling service, so any doctor can call the BMA counselling service. You don't have to be a member anytime, day or night, and you will receive expert support. In fact, we've been our busiest in the last few months. In June, was the numbers of calls have increased by 40%, and June was a record month. We've never had so many doctors seek help. We also provide support for any doctor who is undergoing a GMC investigation. So we provide pastoral and counselling support. And that is, of course, I don't need to tell any doctor here that this is a cause of significant mental health morbidity. And tragically, so many doctors have taken their lives whilst awaiting a hearing. And so we provide that support. It's much needed. And it's an important part of our service. We also have a well-being stakeholder group, and in fact, Doctors in Distress and others, Practitioner Health, are members of this group. So the BMA, and I'm very committed that the BMA should work in a coalition with all the fantastic and important work so many others do. And we hold those stakeholder alliance groups every, I think, about quarter. And what we've done in that is really raised awareness and the profile of mental health and well-being and the need to address distress among the profession. And we've, in fact, one of the most recent things we did is chart out a well-being support map in all parts of the UK so that any doctor can have a range of services they can turn to if they need. In terms of our commitment to this area, in 2018, our past president, Professor Dinesh Bugra, many of you will know because he was also a past president of the Royal College of Psychiatrists, amongst many other roles he's held. And of course, his interest in mental health meant that in 2018, we put a lot of our time in a major project on looking at the mental health of doctors and medical students. And this was a very intense piece of work. We did a survey of 4,300 respondents, doctors, but also many focus groups. And what that really sadly showed, and if you're more interested, if you go on the BMA website, you'll be able to see this. If you just type in BMA well-being, you will see the results of this piece of research, which showed that about 80% of doctors had stated that they were at high or very high risk of burnout. Now this isn't a political piece of work. This is what the focus group surveys showed, and it's really, really striking. And when I heard about the tragic story from Amandip, that he said that 2 years before he lost his brother had symptoms of burnout. And I think one of the key messages I hope we will take away here is that if we want to get this right, we have to address the root causes that result in doctors feeling distressed and having burnout, and of course enabling doctors to seek help. But in that survey, 27% of doctors reported that they had a current or past diagnosis of a mental health condition. And I don't know, the experts around here will tell me how that compares to the general population, but what that shows is that doctors are no different from the population. We're not actually somehow more resilient. We're not actually immune from mental ill health. And yet I think very few doctors would openly speak about their mental illness. And yet 27% have had diagnoses. 40% in that survey talked about suffering symptoms of stress, psychological or emotional distress. Again, that isn't the picture of what people say when you meet them as colleagues. What was interesting and important in that survey and research is that 90% of doctors said that their work and related to or was a cause of their mental distress. And the sort of reasons cited, which will not surprise you, were things like working long hours, things like feeling unable to do your job properly, feeling that what you were trained for, which is to care for patients, were not possible under this mismatch between demand and capacity. Issues around the working conditions and so forth. You will be familiar with that. But the point is that if we are to address improving well-being, we have to address the environment doctors work in. Now, of course, not all pressures that doctors face are caused by the workplace. We are human beings. We have all sorts of stresses, personal stresses, but the environment that we work in just adds to that problem. So if a doctor has a personal stress outside work, the way we work does not allow for, well, it just adds to that pressure. In fact, the majority of doctors told us that they would not seek help, and they were not seeking help within their workplace. So they did not, like you would expect, with the provision of occupational health services in hospital, you would expect an employee to go to their workplace if they feel that their workplace is causing them mental ill health or harm. But doctors do not do that. The vast majority go outside because they don't feel comfortable. It relates to what others have said, the fear of speaking out, of how they may be perceived. And there's something about perhaps it's a very unwell system we're in if somehow being open about yourself makes you feel you won't advance in your career. That would, in my view, be an attribute of a very insightful doctor, a doctor who's probably going to be one of the most, has attributes of showing care and concern, but yet we don't seem to do that. And of course, fear of blame. We've talked about this, and we know that doctors are extremely worried that they will be blamed if, and our own BMA research shows that there is a very racial bias here, that twice as many doctors from a BAME background will be unwilling to speak out about concerns because they feel that they would somehow suffer consequences of speaking out. So there is a whole cultural issue here that needs to be addressed. When you then look at COVID, as Simon correctly points out, has not brought a new dimension, but it has exacerbated and added to pre-existing issues. And we carried out a very large survey in the midst of the pandemic, where doctors who said that 34% said that their mental health distress and those that had suffered other conditions, mental health conditions, had actually worsened during the pandemic. That's not surprising when you actually put together the picture of doctors working with changing hours, doctors changing specialties to do new tasks, relearning skills in intensive care, doctors leaving home to work in Nightingale hospitals. Many actually had not gone home for long stretches to protect their own family's health. Of course, being afraid of their own mortality, seeing so much death in more than they'd seen in their careers in the past in a very short space of time, having personal protection, worried about what that may mean, not for themselves, but if they became infected, for their loved ones. All of those concerns, fears have been part of being a doctor in recent months. And again, coming back to the whole BAME issue, the fact is that BAME doctors didn't feel able to speak out and did feel that the system was placing them in danger and they weren't able. And all of this, of course, creates distress. I don't think we'd ever have thought that there'd come a day when a doctor in hospital would have to hold a smartphone to allow a patient in their dying days to contact their loved ones. I mean, I just don't know what, I mean, I'm a GP. I don't know what it must have felt like to have been working in that sort of environment where no visitors were allowed. So, and of course, social isolation. We've not been immune as doctors from the fact that we have not been mixing with others. We haven't had colleagues to turn to. So the past few months and the months to come will continue to add that pressure that we are isolated. Now, the BMA has supported the cause of supporting doctors during the COVID crisis. We've, through our arm's length charity, BMA Giving, have given grants to a joint venture between BAPIO and Doctors in Distress, and also to Doctors in Distress to support doctors you know, in terms of their mental health during the COVID pandemic. And we've also given a grant to the Mind charity as well. So we're very committed as an association to really support the cause, because I think that we should really think of this as a preventative strategy, because what we need to do is put in place an investment in doctor well-being. And I'm minded to, you know, to highlight a really important research last year commissioned by the GMC, which was caring for doctors, caring for patients. Michael Weston done the COIA report. Those of you, I'm sure you're familiar with that report, which also shows that improving well-being in doctors, or rather removing distress, isn't just the right thing to do morally for doctors, but it actually, distress impacts, or lack of well-being impacts on patient care. We know that our thought processes, our coherence, the ability to actually digest information, and it's been shown that it impacts on our ability to be competent doctors. So I think there is a real calling now to see well-being as an area of investment by the NHS, an investment in healthcare practitioners to be able to actually perform better. You'd have less sickness, you'd have greater productivity. There is a very strong economic argument, let alone a moral argument, to actually invest in that. And part of that investment has to be to address the workplace environment, and not just the physical environment, because we certainly have, as a BMA now, got the Fatigue and Facilities Charter, which has stipulated the sort of practical workplace improvements we need. But we also need to make sure the culture in the NHS changes. And I don't need to repeat all the sort of aspects of that, but we certainly have not got it right at the moment. And that's probably, you know, one of the key challenges we have, but something we must do for the health, both of healthcare professionals, but also for the nation. So I'll stop there. Thank you very much for listening.
Thank you very much, Chaand. And I think sorry, JS. I was going to say, I think the chairmanship's now handing over to me. That was very, very comprehensive and a sort of run through of what the BMA is doing, which is, and through your leadership, is doing some fantastic work. So we've now got a little bit of time for comments and questions. Not much time because the richness of the discussion, JS and myself are chatting with each other privately there, but it was so rich we didn't want to interrupt it. But rather than ask people to ask questions, we've been picking up some of the themes that have been there. And if I just sort of kick off, really, there's two very good questions. One is, I think if I put it to Lewis, and if you could be brief, because we haven't really got much time, but the other one to you, Ananta. The one to you, Lewis, is there any suicide prevention, not just in doctors, but in anywhere, that is proving successful? And the one to you, Ananta, is, in your studies, has anybody done this right for doctors? Can you sort of, you know, so Lewis, what are the suicide prevention strategies that you've seen work?
Well, do you mean in general? I mean, suicide.
The question sort of asked in general. Now, of course, that's an enormous topic, but of the, you know, what are the ones immediately? I said it. What came to mind? I mean, is it rails at railway stations to stop people jumping in front of trains? Is it? Yes.
I mean, there are obviously. I was saying that suicide prevention is not one thing, and we shouldn't rely on one thing. But suicide prevention starts with some fairly basic things. So it's right to talk about identifying and treating people who get into more serious difficulties, who get depression and more serious illnesses. But it is also, prevention starts with quite simple things, treating people well, respectfully, asking about your colleagues, good working conditions, the environment where you work in emotionally and physically. Getting those things right isn't necessarily what we think of as suicide prevention, but that's where it starts. And that's what we have to do for the health professions. But then we have to have the services that will treat people who are going to get into more difficulties. That includes crisis support for people who get into an escalating risk. So all of that that service response, that support has to be right. You're also referring to, I think, though, that reducing access to means, which can sound like a rather mechanical way of going about reducing suicide risk, but it's probably one of the best researched, best evidenced approaches to suicide. And in the case of doctors, there's a particular concern that knowledge of and access to important suicide methods through the use of drugs, that's easier. They're expert in the drugs that might be fatal, and that's potentially harmful. And so getting that part right, the access, the vigilance of colleagues, that's also important. I want to mention just one other thing as well. I mean, there's a long answer and a short answer. I'll try and give you the in between. The other point then is about the media. The media is always interested in doctors who die by suicide. There is a hero narrative. The hero who fell onto hard times is a very powerful media story, and it's been particularly prominent during the COVID era. So I do think that getting proper media reporting, respectful, rather sensitive media reporting when deaths do occur, is also a vital part of it. We know that poor media reporting allows people to identify with the person who died. And so protecting potentially vulnerable people from the details of a death that's occurred, not presenting it as either romantic or logical or inevitable, that's also a very important part of getting the story right.
Sorrows of Young Werther, which I think you shared my Journal Club at the Maudsley Hospital. Another milestone that you've been present at, Lewis. Thank you. So Ananta, briefly, because we've only got a few minutes left, literally a few minutes, we've only got 5 more minutes. What has any country, and you're on mute, has any country done it? This is specifically for doctors. What have you learned in a nutshell?
Yeah, thanks, Claire. Again, I think, suicide prevention is about a multi-pronged approach and a systemic approach. I mean, in our country, the practitioner health program has been getting good outcomes. I've seen the 10-year report, and I know you've been doing some fantastic work, and that again brings a range of things together. When I went to the US on my Churchill Fellowship, I was very privileged to spend time with and be hosted by Professor Michael Myers, who's been, from whatever I know, he's been running the longest, he's been running clinics for doctors for the longest period of time that I know of, for over 25 years, I think. And there's something about the sustainability. And he's had outcomes, good outcomes across all groups of doctors, right from medical students. And what I found that has helped, I don't know about getting it right, continuously, but what has certainly helped in his case, which I learned from, is about having that continuity of approach from medical school right to the hospitals, and being able to work as part of a system. So for something like suicide prevention to work, I think we need to get, for want of a better phrase, the primary prevention, the secondary prevention, and tertiary prevention right. So the early things we've talked about, like, the environment right and valuing people and the working conditions, and then actually getting help for people when they are stressed and at burnout level rather than being seriously ill, and of course then having bespoke services. So that continuity, that multi-layered approach, and the regulators, providers, managers, everybody working together, I think is really important. All of them are inextricably linked. So we need to have, in our country, I would say it calls for NHS providers, GMC, Health Education England, care providers, universities, all working together to make sure that this is a joined up approach. So that's what
I'm going to hand over to JS now. And before I do, because he'll close the meeting when it comes down to it, Doctors in Distress is the only charity that deals with prevention as well as treatment. And if you wanted to give generously to us, that would be really, really lovely. And details are on the front, and also you can get through our website. But also I will be publishing a book in about 3 weeks' time called Beneath the White Coat, Doctors' Mental Illness and Their Minds, where the proceeds of the royalties will go to Doctors in Distress, which will pick up a lot of the themes that we've been discussing here, but also pick up some of the themes that have been put into the chat box. So not to blow my own trumpet, but if only to raise money for Doctors in Distress, please buy the book. Thank you. JS, over to you.
Thank you very much. And you've given me adequate time, 3 minutes. And I think we've been really completely, we're blessed in a way, because for a topic that is really, in some ways, rather sad and rather tragic, it's brought to us the experience of Amandeep and his family from the serious loss that he endured, to issues that are really quite germane to helping medical profession and other people. And we've heard so much from Louis Appleby, who is the Tsar, who tells us how to do it. And there are many things that he said which he couldn't say today in terms of prevention, which is actually embedded in the National Health Service throughout, from even his dear Scotland, where he wasn't a Tsar, but that has worked. And as a medical director, I look to the prevention that he and his team, we was in Manchester as medical director. That was what I had to do. Suicide prevention strategy does work, but it's a wholesome approach. And we heard from Simon Wessely about his experiences in forces, and also in the burnout and what's going to come from the NHS. It's slightly realistic note about where we're going to be, and watch out for each other, he said. And I'm going to come to you, Subodh. You're the man who's made it happen. And of course, Chaand Nagpaul, who's absolutely brought to us the huge experience of the BMA in terms of the support that they give to doctors, and also the stress felt by doctors, the burnout that doctors have felt, and medical students. I shouldn't forget medical students as well. And Ananta, her personal experience of Churchill Fellowship and as medical director. So we're really hugely privileged. And Subodh, what a man you are. I don't know what your next challenge is going to be, but it'll be an absolute doddle compared to what you've done, I suspect, for the 806 or whatever miles you covered over the bike, just to raise money for Doctors in Distress. I do want to say from Bapio that Thank you very much to everybody for coming here. It was an idea that I just kind of dreamt of, and Clare made it happen, and Subodh, you were the absolute catalyst to this. I'm very grateful to all of you who are personal friends as well for being here and giving your time, and all the delegates or participants who've been there. I'm sorry we've not been able to answer all your questions. There were questions about stigma, questions about mental health being right in the curriculum, right from the start. We heard from Simon that consultants and perhaps GPs are being much more supportive of junior doctors than we've ever been before. And please, can we carry on with that? I do hear from many junior doctors that actually supervision is not what it should be. And I think we really need to put the art of supervision back on the back of this. There's so much that can change through COVID, which could be very positive and will be positive. So watch out for each other, folks. Thank you very much. Look after yourself, look after your loved ones, and have a good evening. Thank you.
Thank you. And we'll save the answers, the questions, and we will respond with them to you. Thank you so much, everybody, for joining.
Clare, I should have said this is a recorded session.
Yes, it is a recorded session.
And of course, yeah, go on, Clare.
Well, I was going to say it is recorded, and we'll find a way of making sure it goes onto the Doctors in Distress website and anybody can access it.
And News, both. We'll put it on both.
And on Twitter.
Yes, thank you to you, because you are a star. You're so supportive, and BAPIO have done an incredible amount of work to support all doctors, but especially doctors who actually struggle. And thank you so much. Thank you, everyone. Have a nice evening. Good luck.
Good
Take
evening.
care.
Bye.
Thank you.
And buy Clare's book.
Buy my book.
Buy her book.
$24.99. Bye.
Bye.